The Ontario Tories think they can restructure healthcare so dramatically they'll save hundreds of millions of dollars and give thousands of bureaucrats their pink slips. Joining us now with more on his party's prescription for health reform, here's Tim Hudak, leader of Her Majesty's Loyal Opposition, and the MPP for Niagara West, Glanbrook. Good to have you back in that chair.
Thanks for being back on the show,
no,
Steve.
Not at all. Thanks for coming in tonight. There are, I guess, 7 key recommendations in your patient-centered healthcare discussion paper, and we want to let everybody know that if they want to see all 7, they can go to our website. There's a full link to the report there.
Perfect.
Plus theagenda.tvo.org for that. We're going to focus not on 7 things, which we don't do here, but just a couple of things. And I want to start with the LHINs, Local Health Integration Networks. You want to eliminate those. You also want to eliminate the CCACs, Community Care Access Centers. Before we talk about why you want to get rid of them, why don't you start by telling us what they do now?
Sure. Well, the problem in our healthcare system is we have so many layers of bureaucracy. And often when people have to move between the different parts of our healthcare system, you got to fight like hell to get something done for a patient in the system. So the LHINs were created by the current government, I think 6 years ago, 2006 or so. And they were to sort of manage healthcare on a regional basis. There's 14 across the province. And these things have happened in other provinces. Ontario's structure didn't give them many teeth. They're to make recommendations, make plans. At the end of the day, I'll argue during our discussion, they've been a dramatic failure and they've wasted a lot of money that could have gone to frontline care. The CCACs, Community Care Access Centers, were actually created by the PC government under Premier Harris, of which I was part. It was an improvement in 1996 on the existing fragmented system that was largely municipally run. CCACs are those who coordinate home care. So if you have somebody recovering from surgery in hospital at home, you have an aging parent who needs a visiting nurse, for example, you call your CCAC. It's a good process. Problem is, after 17 years now, 16 years, heavily bureaucratic. They've gotten farther away from the people to the point where 30 cents in every dollar that should be going to home care is going into administration. Our plan is clear out these layers that get between the Ministry of Health and doctors and nurses and patients they treat and invest those savings into frontline patient care.
They're not doing, in your view, what they ought to be doing, but presumably they're still doing something, coordinating care, allocating resources. If you scrap those 2 bodies, who does that work?
Start with the CCACs. So the CCACs, as I said, put 30 cents every dollar into administration. I'd rather see that go into patient care. Our proposal is to create what we call health hubs at a more local level, building on what is a strength in our system, not perfect, but a strength, our hospitals. And then the coordinators and the frontline nurses in the home care, they would continue to work, but under this hospital hub model. And this means that instead of when you move between the hospital and home care, whenever there's that handoff, sometimes people fall between the cracks. You'd have seamless healthcare between a visit to the hospital or from your doctor's office to the hospital, back into home care, or if you need long-term care. Basically, our plan would knit together all those aspects of the system so you can actually move through quickly and efficiently, as opposed to the current system where you tend to drop through the cracks.
Is the hub run by the hospital?
The hub would be based on the existing hospital board model, but it would evolve. We'd expand the people on the board. Volunteer-based tradition like we've had is strengthen our system as well, the hospitals. But you'd expand their mandate then to coordinate hospital care, so the acute care side, community care, home care, and long-term care. And then for the first time in the history of our province, we would link in primary care from our physicians. But we all love our docs. They do a great job for us. But right now our doctors really don't play a role in determining services provided at the hospital, the community care programs. And so you actually link them in, so you bring in that part of the system that currently doesn't happen under the LHIN model.
And how many hubs would there be across the province?
This is what we're consulting on in our white paper that's available on your website or ontariopc.com. When we developed the paper, talking to health experts, they recommended between 30 and 40 different hubs, regions across the province.
How does 30 or 40 sound more efficient than 14 LHINs, which is what we've got now?
Because you're clearing out 2 layers. I mean, you're building on, we already have hospitals. In fact, we've had a strong history of hospitals in our province providing quality care. There are things we can do to improve them, make sure there's greater accountability, break down some of the walls that have about 20% of every the hospital beds that have what they call alternate level of care patients, people who should be receiving home care or long-term care. But you build on what's already there, so you're not creating a new layer. You clear out the LHINs and the CCACs, so money is more directly going to patients, and you also then streamline the care so people aren't bouncing around the system. And instead of having 4 CEOs all empire building, sort of warring against each other, you're going to have it at one particular site to break down the silos and make sure there's a smooth movement between aspects of our healthcare system.
Let's do what Woodward and Bernstein suggested and follow the money, because I remember at your kickoff news conference on this, you said it's about time that we had healthcare dollars follow the patient. What do you mean by that?
Here's what I want to see in our healthcare system. You know, I'll just use, I don't know if my mom's watching at home, and who is in wonderful shape, by the way, much better shape than I am. But let's say my mom had to have knee replacement surgery. I'd like her to have, you know, the evidence of where she can get the best care anywhere in the province, the outcome from a quality care point of view, and secondly, how she's treated from the moment she enters the hospital to follow up physiotherapy at home. So first, give her that information. And then if she chooses to go to a hospital in Niagara where she lives, she chooses to go in Toronto or in Hamilton, let the dollars follow where she moves in the system. That's what we call the patient-focused funding. That will incent quality of care, it'll reward excellence in the system, and also create efficiencies. It's a new way of funding our healthcare system, but I think it will actually be a big, bold change that will enable much better quality care on the front lines.
I know sort of administrative structural restructuring of the healthcare system is not necessarily the sexiest topic around, but it is important, and I think the Liberals would say we went through a massive reorg 6 years ago, and the last thing, you know, the system we have right now might not be perfect, but the last thing we need to do is throw the baby out with the bathwater and start from scratch. You want to start from scratch. Are you concerned about what that transition could mean?
I'll disagree with the premise. I think I'm going to instead build on what's a strength in our system. And while they may not be perfect, our hospitals in Ontario are recognized among the best in Canada. So let's build on what works. Great frontline community care, as well, but not enough dollars are actually going to the visiting nurses and physiotherapists and occupational therapists. These are strengths. Let's build on them. What's not working in our system? The LHINs have been an abject failure. I mean, they've been condemned by their lack of results. The ministry's own studies have shown that 78% of the targets were not hit by the LHINs. And Steve, if you pay somebody their full-time job is to plan, you get all kinds of planning. They're great at renting halls for plans, conference centers. They don't deliver care. And if you don't believe me that we need this change, then Don Drummond looked at this very closely. He looked at a number of models. He said there's two ways to go. You can do LHINs 2.0, which is basically give them the keys to the system and more teeth, or the hospital-based hubs. I prefer the hospital-based hubs because I want people who actually spend time with patients that actually deliver care rather than planners to run our system.
No, I've talked to lots of people who are in healthcare around this as well, and one of the things I hear is you probably want to get rid of one of them, but to get rid of both of them is really pretty significant upheaval in the system. It's hard to get from here to there. That doesn't concern you?
We need to maximize every one of the $47 billion that we're going to be spending in healthcare to make sure every dollar actually goes to patient care. And clearly, Steve, if something is failing in the system, you change it. You don't try to shore up a crumbling foundation with the 2x4, right? That might work for a little while, but it's not going to be a fundamental fix. So the LHINs, I think they should go, and I think there are a lot of people who support that. The CCACs, too top-heavy, too administrative, too out of touch with people. So those that are working in the system, the actual frontline delivery, bring them into the hub. You can actually increase it. I'd rather spend the money, let's put it that way, on visiting nurses than more and more administrators, middle managers, people who spend time with patients, not their entire day moving paper from the inbox to the outbox.
There's a pretty well-regarded health economist named Stephen Lewis, healthcare expert. And he was on this program a couple of years ago. We were talking about LHINs and how effective they are or aren't. Look at the monitor over my shoulder. Here's what he had to say about this. Roll tape, please.
The anger is partly a result of the LHINs actually doing their jobs. The LHINs were set up to integrate services that weren't integrated before. That you couldn't expect programs to work seamlessly together. So whenever a LHIN started doing something to that effect and starting to try to address things such as value for money, coordination of services, and consolidation of services where you needed to on quality grounds or because you didn't have enough money, local people are going to get upset.
He seems to be suggesting that it's the nature of their job to have people angry at them and to be unpopular because they're making the hard decisions about allocating resources and that kind of thing.
But they're not. I mean, with all due respect to Mr. Lewis, and maybe that's the design of LHINs they had in Saskatchewan or out west, the design of LHINs in Ontario sort of went halfway. They make recommendations, they do planning, but they don't actually have teeth to make decisions or coordinate care. They're kind of a weak glue, and that's why they've not made any progress. 78% of them, of the standards that were set for them, they have failed to pass. And let me make this point too. You know, there have been hospital amalgamations that have happened under the LHINs, partnerships that have come together. I think of, for example, Credit Valley and Trillium in Peel region. We have University Health Network and St. John's Rehab. These actually came together despite the LHINs. That actually made sense to them to bring their services together, to shut down some administrative costs, to focus on patient care instead of bureaucrats. But then the LHINs had to do their sort of inspection. They had to jump through LHIN hoops. I think it's the opposite here in Ontario. I think the LHINs are an obstacle. They're in the way. They're a drain on the system, $300 million to date, that I'd argue be much better put towards patient care.
So you'd scrap them and fire everybody who works for them?
Well,
just want to be clear on that.
Well, I'd eliminate the positions, let's put it that way. I mean, and I think there are about 2,000 middle management, bureaucratic positions at the LHINs and at the CCACs. And these are folks who don't spend a single minute of their day with patients. I would much rather invest that money with those providing patient care. Will we see some at the university hubs having to take more people on? It may be the case in certain areas, but they already have to do that. Hospitals will have folks who are currently working with the CCACs, others that work with long-term care, with community care. We have almost like a hub system where the spokes go out in opposite directions, but nothing is actually bringing them together. The LHINs were supposed to do that. They have failed to do so. They're condemned by their own lack of results. You have two paths to go unless you want to keep having a significant leakage from our system. You could strengthen LHINs, give them teeth, help them run the system. I think that's wrong because it puts more authority to health planners, not health practitioners, and takes it further away from the people. In my area, for example, it stretches from Fort Erie all the way to Brant, not exactly a community of care. Or you can put more decisions in those who spend their day working with patients that actually run the sophisticated part of our system, and you can make it more local, closer to the people.
Well, let me pick up on sophistication, because this is a $47 billion, as you pointed out, annual healthcare expenditure system that we're dealing with here. And the folks who run it, okay, I get you don't like the job they're doing, but they are pros. And you want to replace them with a volunteer board, and the volunteers, even the volunteer boards of hospitals, are not pros in healthcare. They may come from all over the, from all over the spectrum. That's a lot of expertise to be giving up in favor of people who are not experts.
But respectfully, hospital boards already are running corporations that are in the tens, hundreds of millions of dollars, way larger than what LHIN budgets are. And in many circumstances, with respect to those who are working at the LHINs, they couldn't qualify for a big job at a hospital because they don't have that background. I would put my faith more so in people who spend their day working with patients and tearing down these walls. Let me give you another example of what's not working in the system. If the LHINs were supposed to solve our problems over the last 6 years, then why have wait times for long-term care spots doubled? Why do we have 20% of beds occupied by what they call ALC, alternative level of care patients who should get home or long-term care? Because we have all of these silos. They're not working together. The LHINs have failed their job to tear down those silos. So why don't we actually then build it around and strengthen our system, around our hospitals, tear down those silos, because I know that the hospital administrators, the hub boards, they'll have the incentives then to get people out of the bed blockers out, put them into community care or into long-term care. They're going to have that financial incentive to tear down those walls that currently we're not doing.
Since we're being so respectful of each other here, you said respectfully, I say respectfully back. I've listened to politicians for 30 years say they're going to break down the silos in healthcare, and each one after the other says, I got a great new idea for restructuring healthcare. It's still here. The silos are still here. What makes you think this is going to work any better?
We're going the opposite direction. The previous approaches, including the LHINs, were to take decisions away to take it up to a higher level. Other provinces have looked at ways of coordinating care. They've looked at ways of doing regional health planning. And you can go one or two directions. You can take it up higher, more decisions to the LHINs, or put it more at the grassroots level. That's the direction I want to go. That's why I'm confident we can actually do a much better job at maximizing every dollar to put it towards patient care. And there's no doubt the current system isn't working. I think you talked to her one time, a woman from Port Colborne named Ruby Conway, a real icon in the community. She used to say all the time, she's passed away now, make some noise, let them know you're there. So often in the healthcare system, if you don't, your loved one falls through the cracks. They don't get the attention they need. The current system's not working. I believe our plan will actually make it work a lot better and put patients at the center of the healthcare system, not more bureaucrats, not politicians, patients.
Support Ontario's public television. Donate at tvo.org.